Muy buenos días a todos. Soy Dagoberto Delgado y a nombre de la Federación Nacional de Neonatólogos de México y de su presidente, el doctor Moisés Quiles, le damos la bienvenida a la sesión del día de hoy. La sesión académica del día de hoy es Probióticos, estamos listos para su uso de rutina. Nos acompaña el doctor Soll, que es profesor de neonatología en la Facultad de Medicina Larner de la Universidad de Vermont. Es vicepresidente de la red Vermont Oxford y director de la red de ensayos clínicos y de seguimiento. El doctor Soll es una autoridad en medicina basada en evidencias y ensayos clínicos aleatorizados. Siendo editor coordinador de Cochrane Neonatal, ha sido colaborador, autor y coautor en muchas de las revisiones Cochrane de la terapia con surfactante, así como autor de numerosos artículos científicos y libros relacionados a terapia de reemplazo con surfactante y medicina basada en evidencias. Él es originario de la ciudad de Nueva York y cuenta con múltiples grados académicos, entre ellos el título de Genética e Historia de la Ciencia por la Universidad de Cornell, Medicina por la Escuela de Medicina de la Universidad de Ciencias de la Salud de Chicago, Pediatría por la Universidad de Nueva York, Neonatología y Medicina Perinatal por la Universidad de Vermont, donde se ha desarrollado su práctica profesional desde entonces. En sus tiempos libres, reside en Hillsborough, Vermont, con su esposa Roberta y en compañía ocasional de sus dos hijos. Le damos la bienvenida al Dr. Soll para desarrollar el tema de la sesión del día de hoy.
Thank you very much, Dr. Delgado. It is a great pleasure to have a chance to speak to you today. I'll start with apologizing for addressing you in English. Although a native New Yorker, I have no facility at language, and I speak only one language, and that I speak poorly. But with your patience, we'll have a wonderful interaction in session regarding the use of probiotics. So let me share my screen, and we'll begin our discussion. So I hope you're seeing the slides now. This morning, I'd like to talk to you all about the evidence behind the use of probiotics in preterm infants. And I think what you will see is that there are strong potential benefits, but also real concerns. And at the end of the day, although very impressed with the possibility of probiotics, I am left with a degree of uncertainty. And so I'd be very interested as we share this evidence that we also have a chance at the end of this discussion to talk more about what the view in Mexico is on the use of probiotics and why you might consider or not consider adopting this in your practices. Let's just start quickly with some issues of disclosure. I am the vice president of Vermont Oxford Network, a not-for-profit collaboration of over 1,200 neonatal units, and some of the data I'll be presenting today will come from that collaboration. I am also the coordinating editor of Cochrane Neonatal, and the core of the evidence basis that I'll be discussing will come from work that has been done and published through Cochrane Neonatal. Otherwise, I do not believe I have any other relevant financial issues to discuss. Our goal is to develop an understanding of the strengths and the weaknesses of the evidence provided by systematic reviews and meta-analyses to inform our practice regarding the use of probiotics in preterm infants. And to begin with, let's agree that there is a real problem that we think we might be addressing with probiotics. Necrotizing enterocolitis is a devastating illness that stays with us and affects almost 1 out of every 12 infants that we care for. Here is some data from Vermont Oxford Network looking at the 21st century through 2017, and we can see that there is a 5 to 7% incidence of necrotizing enterocolitis in very low birth weight infants. So this means that a significant number of our babies that we care for will experience this devastating disease. Here's a figure that shows what we think all the contributing factors might be to causing necrotizing enterocolitis. The core issues are some aspect of gastrointestinal compromise, whether it's based on just immaturity, based on inflammation, based on injury such as hypoxia, the issue of bacterial overgrowth in the intestine, so pathogens which may be external or endogenous, the possibility of the lack of probiotic organisms, and then there may be the exposure to enteral feeding, whether it's formula or human milk, how we time our feedings, how we advance our feedings, and how much feeding we give. So there are many possible routes that contribute to causing necrotizing enterocolitis. But I have a personal theory. I believe that the more arrows you see on a slide, it's inversely proportional to our understanding of the process and what's really going on. So when we see so many arrows, that both says that we have some understanding of the process, but to my mind, it also says we have a fair degree of uncertainty about the process. So let's go through what we do know, first about necrotizing enterocolitis, and then what we know about probiotics. What we know about necrotizing enterocolitis is that breastfed babies have a much lower incidence of necrotizing enterocolitis than formula-fed babies. And that's clearly one of the most important issues regarding our choices in our care of preterm newborns. It is unclear whether or not various feeding regimens really do contribute to the etiology of NEC, and more importantly, whether or not any choices we make regarding these feeding regimens can prevent the development of NEC. Although conventional wisdom recommends slow initiation and slow advancement of enteral feeds for preterm infants, randomized trials do not show an increased incidence of NEC for babies in whom feeds have been started earlier in life or in whom feeding advancement has been more rapid. In fact, perhaps just the opposite. So then the question is, what about probiotic supplementation? Is there a role to improve the colonization of the gastrointestinal tract through probiotics? Well, there is a very strong rationale to suggest that this could be successful. We know that we are inhabited by as many as 10,000 bacterial species. These cells outnumber those of which we consider to be our own by 10 to 1, and all told weigh about 3 pounds, the same weight as our brain. Together, we speak of them as the microbiome, and they play a crucial role in our health and well-being. What might some of the functions of the microbiome be? Well, from a point of view of metabolism, they're very important in the synthesis of vitamins, in the digestion and breakdown of harmful compounds, and the fermentation of non-digestible substances, and they have a role in energy production. They also protect us. They stimulate the immune system. They have an antimicrobial effect, and they even create a physical barrier against pathogenic bacteria. So clearly the role of probiotics and the microbiome is key to our health and well-being. At birth, the infant's gastrointestinal tract is essentially sterile. Now, you will read of some transmigration of bacterial even to the fetus. This may or may not have an important role in GI development, but there is not the huge numbers of bacteria that you see post-birth. So the fetus essentially isn't exposed, it isn't colonized, and does not have a developed microbiome. The colonization of the gastrointestinal tract starts immediately after birth with the initiation of enteral feedings, and in normal term babies is well established within the first few days of life. The intestinal flora varies widely from person to person, And in adults, we discussed this before, 100 billion bacterial cells comprising more than 40 different species can be found. This is some interesting work looking at the development of the infant microbiome. And what you see in this very colorful figure is the microbiome of infants who were either delivered vaginally or by cesarean section. And what you can see is that here in the middle, for babies delivered vaginally, their microbiome mostly shadows the microbiome of the birth canal, of the mother's vagina. But that over here in babies delivered by cesarean section, you can see a vastly different microbiome. What you see is a microbiome that more replicates the microbiome of the mother's skin. And so even the route of delivery will have profound effects around the infant's microbiome. And if we take a look here on the slide in red in lactobacillus, which as we'll come to is one of the common probiotics that inhabit the gut, we see that that is common in babies with vaginal birth and rare in babies who've been delivered by cesarean section. In formula-fed infants, coliforms, enterococci, and bacteroides predominantly colonize the intestinal tract. Bifidobacterium and lactobacillus, the common probiotic organisms, are only present occasionally. However, in breastfed infants, what we see is a predomination of the probiotic bacteria, Bifidobacterium and lactobacillus, with the other enteric organisms being present much less frequently. This pattern of bowel colonization is different in preterm infants in an intensive care setting. This may be related to antibiotic use, to the impact of infection control procedures, to the delayed initiation of enteral feedings. All of these factors for our preterm infants in intensive care may influence the type and the amount of microorganisms colonizing the gastrointestinal tract. Let's take a look at just how different and how unusual the microbiome of these preterm infants is. The GI tract of extremely low birth weight infants are colonized by fewer than 3 bacterial species by the 10th day of life. Remember, we said for term babies, colonization is well established by the 3rd day of life. Species of Bifidobacterium and lactobacillus are found in the stool of less than 5% of patients studied within the first month. So only 1 in 20 have the normal probiotics even identified in their stool. By day 30 of life, so by a month of life, the predominant organisms were Enterobacter and coagulase negative staphylococcal, which coincidentally, when we think about causes of nosocomial infection, these are the organisms that we're most worried about. So let's move on to this issue of probiotics and how they might help us. And the first question, of course, is what do we mean when we say probiotics? Probiotics are defined as live, non-pathogenic bacteria species that normally reside in the gastrointestinal tract of healthy term infants. It has been postulated that introducing probiotics to preterm infants might be beneficial in order to avoid overgrowth of pathogenic organisms. And that specifically is the hypothesis we're going to be discussing today. Probiotics have been proposed to enhance enteral feeding and prevent necrotizing enterocolitis and possibly nosocomial infection in preterm infants. Now, probiotics are a very interesting preparation. Certainly in the United States, and I assume in Mexico, that they are widely available without a prescription as a nutritional substitute. A variety of agents are available for study, including lactobacillus and bifidobacterium, which are the predominant species that we see in human microbiome. and they are commercially available in different forms and different concentrations. So much so that for good or for bad, there are even infant formulas that are marketed that include probiotic supplementation. I'm not bringing this up to endorse it, far from it, but I'm just saying how far down the line we have gone with the possibility of probiotic supplementation, not so much in the preterm, but in infants in general. So let's take some time to evaluate the benefits and harms that we know about probiotic supplementation. The desirable effects, both how substantial are these effects and how certain are we of the data from the trials, as well as the undesirable effects. And importantly, again, evaluate the evidence to take a look about how well done these trials are and whether or not we feel certain in the estimates that they give us. So let's start with a simple question, more from the nutritional point of view. And the question is, does probiotic supplementation improve growth and feeding tolerance? And you'll see in most of the slides I'll be sharing with you this morning, I will look at large numbers of trials and synthesize that data. But when it comes to continuous measures like growth, it's a little easier to understand the impact if we choose one study that seems to represent the types of outcomes we see, as opposed to just presenting the amalgam of all the studies. And towards that end, I've chosen the study of Kitajima and colleagues back from 1997. It's a single center randomized controlled trial, not of large numbers, only 91 infants, and they were randomized to receive either a bifidobacterium probiotic, single species, or control. It's a small number of patients, and we wouldn't expect to find important clinical outcomes, the downstream outcomes, but it's actually a very good population for looking at how things like growth might be affected by probiotic supplementation. And this gives you a pretty good idea that the infants here in black who did not receive probiotic supplementation, they tolerated lower feeding volumes than the infants who did receive probiotic supplementation, and not by a trivial amount. We're talking about differences of like 130 milliliters per kilo per day versus 150 milliliters per kilo per day. And so when we look at Kitajima's data, we say that there seems to be an important benefit of probiotics on feeding tolerance for feeding volume. And the fact of the matter is, in Kitajima's data, that also shows up as an improvement in growth, not surprisingly. So we see that here, after probiotic supplementation has been initiated after the first week of life, there are two very distinctly different growth curves in terms of how these very low birth weight infants grew, with a distinct advantage in growth with the babies who received bifidobacterium. Well, that's all well and good, but I don't think you'd be inviting me to speak this morning unless there were other more important and pressing issues that could be addressed by probiotic supplementation. So really, the big question we have in mind is, does probiotic supplementation improve clinical outcome? And particularly based on what we understand about the impact of the microbiome, does it decrease infection? Does it decrease necrotizing enterocolitis? And does it decrease mortality? Does it improve survival of these infants? Well, towards that end, I will now look at the huge aggregate of data that has been accumulated on this subject. And it is well represented in this work of Sharif and colleagues in the Cochrane Library that was published in 2020, looking at probiotics to prevent necrotizing enterocolitis in very preterm infants. I think it's important when we look at the PICO question, the population, the intervention, the comparator, the outcome, that we are really restricting this to the very low birth weight infant or very preterm infant. There are a fair number of studies in the late preterm infant, and there are potential advantages. But when it comes to diseases like NEC or even dying from complications of prematurity, I think we want to look at the really high-risk population. And so we'll look at very low birth weight infants and ask whether or not enteral probiotic supplementation compared to routine feeding management improves morbidity and mortality up to 2 years of age. Well, of all the meta-analyses and systematic reviews that we have published in Cochrane, there's perhaps more evidence and more to say in this trial, in this review, than virtually any other one. There are 53 trials, which involved over 10,000 preterm infants. The risk of bias varied based on concealing and blinding the use of probiotics, and the variation in timing, dose, formulation, is there, but still, I think ultimately it is worthwhile to look at the data in aggregate. However, there is literally, with that number of patients and that number of studies, it's like a tidal wave of information. Here, we're looking at the forest plot, looking at the effect of probiotics for the prevention of necrotizing enterocolitis in preterm infants. I don't think any of you have ever seen a forest plot. Here we have the studies on the left, the individual plots for the risk ratio here, with some breakdown based on the type of probiotic, and ultimately the typical estimate down here. Not possible for us to discuss each of these studies, and so what I will do is talk about the aggregate results. So here we have the big ticket points from the meta-analysis. In infection, there were 45 studies that reported on infection involving over 9,500 infants. And we see a small reduction in infection. We have here the risk difference, so that's the absolute difference versus the relative risk. We see about a 10% reduction in risk of infection. When we look at the risk difference, we see it could be as much as a 4% reduction in infection or as little as a 1% reduction in infection. The point estimate is a 2% reduction in infection, which means that for every 50 preterm babies we treat with probiotic supplementations, we'll see one less infection. When it comes to NEC, we see a somewhat stronger result. And remember, NEC is a rarer complication. We see an almost 40% reduction in the risk of NEC. That translates to an approximately 3% reduction. That tells us that for every 33 babies that we treat with probiotic supplementation, we may see one less case of necrotizing enterocolitis. And importantly, in mortality, we also see a risk of mortality from the randomized trials. 52 of the trials and over 10,000 infants reported on mortality, suggesting about a 30% reduction in the risk of death. The point estimate for the risk difference is -2%, suggesting that for every 50 babies we treat with probiotic supplementation, we'll see one less infant die. Now, although that involves large-ish numbers to treat, these are very important clinical outcomes. And so I think it makes most of us as neonatologists and clinical caregivers sit up and wonder, well, this seems like an important result. In clinical trials, probiotic supplementation was not associated with any probiotic-related sepsis cases or, frankly, any adverse effects. There's a wonderful blog that I don't know if you are familiar with in Mexico that is written by Keith Barrington in Montreal in Canada. And he believes that this evidence is very strong. And here's a quote from his blog. "One thing I have difficulty understanding is the lack of clear guidance from either the American Academy of Pediatrics or the Canadian Pediatric Society regarding probiotic use in the preterm. Anything else that had been studied in 63 randomized controlled trials and over 15,000 babies that showed a reduction in mortality and a large reduction in serious NEC would surely now be the subject of neonatal-specific position statements." It's a strong statement, but I would argue that there's more to consider in this. And in fact, since that blog, and we'll end with this in the talk this morning, there have been some more formal recommendations, at least from the AAP. So what more is there? What are the questions that are holding us back from adopting what appears to be a very strong body of evidence? Well, so are more trials needed? Look at that. I mean, a lot of trials have been done. How are we going to get further along to answering this? Well, we need to look at what we really know about the details of probiotic use. So we need to know more about whether or not multiple probiotic bacteria are needed. We need to know about dosing strategies, when to give it, how often to give it. We need to know in the highest risk babies, the extremely low birth weight babies, babies less than 1,000 grams, what the impact is. We need to know in babies who we are really doing our best to give appropriate nutrition, who we are feeding with mother's breast milk or donor breast milk, whether or not there is this degree of impact. And we need a product that is safe and has cleared regulatory hurdles. So let's take a second and examine some of those points about what we do or don't know about these issues that might give us some pause in whether or not we want to use probiotics. Well, here's one that looks at the studies from that meta-analysis I showed you, but groups it by the probiotic products. And as I mentioned earlier, two of the most prevalent probiotic organisms are bifidobacteria and lactobacillus. And some of the studies exclusively used bifidobacteria or lactobacillus, but others used mixtures that included both lactobacillus and bifidobacteria and potentially other probiotic organisms. And I think that what you see is, in fact, there's limited data that feeding exclusively bifidobacterium will improve necrotizing enterocolitis or mortality. So here we see the organism used as a preparation. Here we see NEC and mortality. And although the point estimates suggest some benefit, in fact, the confidence intervals tell us that we are uncertain whether there's a small reduction in NEC associated with just feeding bifidobacterium and whether there's any impact on mortality. If we jump down here to lactobacillus, we see that there is an effect on necrotizing enterocolitis, but a questionable effect on mortality. But when we use more complex mixtures of probiotics, we see more significant benefits regarding both NEC and mortality, suggesting that preparations that include multiple probiotics may be the more effective, but certainly welcoming the idea that if we do test other products in the future, that it really should be these more complex preparations. Then there's this issue of how certain are we about this evidence? And there are ways that we look at the evidence through grade that tells us, okay, randomized trials are great. They start with our highest level of certainty, but there are some aspects of the trials that may make us think, I'm not as certain in this estimate. And they include issues like risk of bias. They include issues like heterogeneity of the populations or the treatments. Indirectness, are these the patients you and I might really want to treat? And imprecision, are the estimates precise enough? As well as issues like publication bias. Is this really the world's experience, or is this only what happened to make it into publication? When we look at risk of bias, here looking at the Cochrane tool for that, we see that in general, over half of the studies were considered at low risk of bias, but blinding was only accomplished in half of the studies. And so there is some possibility of bias that has crept in. And here's an important point that we don't usually discuss when it comes to judging our certainty of a meta-analysis or a systematic review, and that is the so-called funnel plot. It's a scatter plot used in meta-analysis to visually detect the presence of publication bias. So normally, in terms of the control group's outcomes, you would expect them to be scattered in a symmetrical distribution around this sort of tent. An ideal funnel plot is one where the included studies have scattered on either side of the overall effect line in a symmetrical manner. When we see severe asymmetry to either side, such as this figure on the right, there may be an indication that publication bias has occurred. And this is the result when we look at the effect of necrotizing enterocolitis in probiotics. We see an asymmetric distribution in the funnel plot. Why might that be? Well, the fact of the matter is that because probiotics are widely available, many investigators have had an opportunity to test and treat infants with probiotics. And one has to question whether or not in this environment, more of the trials with positive results have gotten presented and accepted for publication. And so there is a hint that we may at least be overestimating the effects of probiotics based on so-called publication bias. When we look at the two largest randomized controlled trials done in populations that probably we would all agree are the most interesting to us. So this is the trial of Jacobs from Australia and the trial of Costello from the UK. Jacobs used a mixture of probiotics. Costello just used bifidobacteria. And what we see is that in these low birth weight infants who are being cared for in settings where there are high degree of receiving breast milk, there's a somewhat more limited effect that only Jacobs shows a decrease in NEC, whereas Costello, with her solely feeling bifidobacterium, does not. And in fact, there are no certain effects on late onset sepsis or mortality. So again, suggesting that in these very methodologically rigorous trials, in settings that either are shadows of our settings, or at least what we aspire to in terms of breastfeeding rates, et cetera, that the effects may be less dramatic. So what else am I worried about? I'm worried about the use of biological agents and our belief that we can control and use them wisely. And I'll share with you two stories, one at a macro level and one at a micro level, which I think will clarify why I get worried about human attempts to use biological entities to treat problems. And this is the story of the cane toad, which I don't know if you're familiar with, but the cane toad is found in Central America and South America. And it eats cane beetles in Central America and South America. And they're very hardy animals, and they're voracious predators of insects and other small prey. And for that reason, people in the sugarcane industry in Australia thought it would make sense to bring them to Australia as a means of controlling pest beetles in the sugarcane industry. But there's a problem. One, cane toads don't like the bugs and beetles that are in Australia. They like the ones in Central America and in South America. And two, they have no predator in Australia. They're supposedly pretty awful tasting, and there's nothing that wants to eat them in Australia. And so they have spread and spread and spread and become a plague in Northern Australia. If you ever YouTube anything about cane toads, you can see in the rainy season when they breed and they hatch out, the roads are just literally littered with cane toads. And so, an unsuccessful attempt to think that we can bring this macrobiologic agent to our uses. And here's an example on the micro level, which I'm very familiar with because it happened during my residency, and in my management of patients, I had to deal with this. And that is the history of Serratia marcescens. Before the 1970s, Serratia was used because it was an easily detected biomarker. It has a distinctive red pigment that you can see in the Petri dish in the lower corner here. From 1949 to 1968, the US Army and Navy experimented with how biological agents and potential chemical agents could spread in an urban environment, and so decided to aerosolize the bacteria to study the way that such agents would spread. This occurred in San Francisco. This included in the New York subway system. Shortly after the experiment, local concerns arose and people started to report diseases of Serratia marcescens, which were multiply antibiotic resistant, which had cropped up in all the wet areas of hospitals. And personally, I remember this as an agent that would infect our preterm infants, would be multiply resistant to bacteria, and potentially kill these immunocompromised hosts. The other issue, of course, is that we introduce these biological agents. Why won't they, like Serratia, become antibiotic resistant? And since they are commensals, they're not going to be killed off by our body's immune system. So are we, in fact, encouraging antibiotic resistance by using probiotics? Certainly, some real problems have been presented, although individual cases, they are scary. This is from the CDC report on a fatal gastrointestinal fungal infection following ingestion of a contaminated probiotic agent. In 2014, FDA scientists confirmed the presence of fungus in ABC-Dophilus powder, which coincidentally was the probiotic agent that was used in the ProPrems trial, and one that was becoming very popular because it had worked in the Australian study, so it seemed like a good choice here. This health alert certainly stopped people from thinking about widespread use of probiotic agents and really pulled us back from fully embracing the evidence that had been emerging. So then I think it's good to sort of end with, all right, well, then what do we actually consider doing? And although Keith Barrington was critical about the fact that there were no recommendations from AAP or other national guidelines, in fact, Brenda Poindexter and colleagues representing the Committee on Fetus and Newborn have in the past year presented a guideline statement on the use of probiotics in preterm infants. And I'm afraid it shares the uncertainty that I've been sharing with you this morning. To summarize their findings, they note that in studies supporting the use of probiotics to decrease the risk of NEC and late onset infections, researchers have used multiple different and diverse products in diverse settings and diverse target populations. You could view that as a good thing, that it's highly generalizable and it may work across the board, but it also stops us from specifically focusing, saying, I know that it's these patients with this product that I should be using. As I noted when I presented the ProPrems trial and the PIP trial of Costello, some of the big modern trials have not shown major impact on NEC or death. Importantly, certainly in the US, and I think this is true in Mexico, a pharmaceutical grade product is not currently available in the United States. And even the products that are widely used, such as Align, or I won't go into brand names, but products that have good manufacturing have not necessarily been tested in the newborn. And the long-term safety, as I mentioned, regarding antibiotic resistance as such is unknown. For this reason, the Academy statement does not support the routine or universal administration of probiotics to preterm infants. They do go on to say that centers making the decision to administer probiotics to select preterm infants should discuss the potential risks and benefits of this therapy with parents and should strongly consider a formalized informed consent process. Such centers should develop local guidelines addressing probiotic use and conduct surveillance to assess local impact, such as checking colonization of your unit. Clinicians must be aware of the lack of regulatory standards for commercially available probiotic preparations, and that centers choosing to administer probiotics should carefully document outcomes, adverse events, and safety. That's a pretty conservative take on this evidence. What do our patients and families think about this? Well, they're a little less concerned, I think, than the Academy statement. Although this work was done in 2014, much of the data was in on probiotics, and they asked parents what they thought about the decision. An information sheet, almost 8 out of 10 thought would be helpful. Only 10% or 12% were worried about the risks. So 9 out of 10 parents almost thought, oh no, the benefits probably outweigh the risks. All of them, almost 96%, thought that they should be informed about this decision, pro or con. And 2/3 of them thought that they should be given an option around treatment. I can tell you today that probiotic use has increased in the United States. This is looking at Vermont Oxford network data overall in very low birth weight infants. And you can see that over 15% of very low birth weight infants are now being given a probiotic supplementation. What does that mean? I don't think it means that in one unit, 15% of the kids get it. I read that more to say that 15% of units have policies about routinely giving probiotic treatment. In a phone survey that we helped conduct, we took a look at this and noted that probiotics were given routinely at that time in around 9% of NICUs, and that the common indications were for feeding intolerance and because the infants were receiving antibiotics. They noted, as I think that the general data notes, that the use of probiotics is increasing, but still far from universal. That said, we come back to the beginning of the talk. Necrotizing enterocolitis has been with us with not a whole lot of change for the most of this century, and certainly for decades. Yes, at the beginning of the century, we had a rate of around 6%, and we're down now to a rate of around 5%. But still, obviously, there's a great deal of progress that needs to be made. So to summarize, probiotics may decrease the risks of NEC and probably improve survival, but we are still left in a quandary about which product, how we move forward to get further regulatory approval, and what might be the role of families and parents in both helping us further the research agenda or in improving individual use for their babies. Are there alternatives to probiotic treatment? It's a whole different talk. Lactoferrin has been proven to be less useful than might be hoped. Prebiotics and symbiotics have not been fully studied. And of course, I think we can all improve our feeding of these newborn infants by supporting mothers in supplying breast milk, fresh breast milk, to their babies and improving our systems of feeding these infants. And so I end with a fair degree of uncertainty, obviously, but hopefully giving you an up-to-date report about where we stand with the use of probiotics in our practice. So I will stop here, and I would love to hear both what's happening in Mexico now about probiotic use, what's available in Mexico now, and questions that you guys have about the work that I reviewed. Thank you.
Muchas gracias, doctor Soll, por la revisión tan magistral de la evidencia disponible con respecto al tema de los probióticos. Vamos a dar inicio a la sesión de preguntas y comentarios. Para continuar con esto, vamos a pedir la participación de la doctora Edna Rosselli con un comentario con respecto al uso de probióticos en la actual práctica médica en México.
Muchas gracias. Buenos días a todos y de verdad gracias por acompañarnos el día de hoy. Y gracias, doctor Soll, por tan excelente presentación, tan estructurada del análisis de la evidencia. Y el día de hoy yo quisiera enfocar mi comentario hacia la historia del uso de los probióticos y el estado actual en nuestro país. En México, la enterocolitis necrosante sigue siendo un problema de salud pública muy importante. Su incidencia va alrededor del 15%, sin embargo, el rango es bastante variable porque, como ustedes saben, también es muy variable la condición socioeconómica de cada estado de nuestro país. Entonces va desde un 10% hasta alcanzar un 20% en las zonas más marginadas de nuestro país. De igual manera, la mortalidad tiene un rango muy variable, que va desde el 10% hasta incluso un 30% o más en estas mismas zonas marginadas que les comento, donde nosotros sabemos que el acceso a esta atención de salud de esta población de alto riesgo, que son los prematuros de muy bajo peso al nacimiento, es muy complicado. Entonces, como ven, es un problema importante de salud pública que justifica que nosotros continuemos tratando de implementar nuevas estrategias de tratamiento y de prevención para disminuir no solamente la incidencia y la mortalidad, sino también la morbilidad y las secuelas que todos nosotros sabemos no son mínimas en estos prematuros que padecen esta enfermedad. Y bueno, nosotros tenemos en México más de 15 años utilizando probióticos en recién nacidos prematuros y en lactantes. Sin embargo, no de una forma estandarizada. Fue más o menos en el año 2009, del 2009 al 2013, donde el doctor Fernández Carrocera realizó un estudio en recién nacidos prematuros menores de 1.500 gramos que estaban alimentados con leche materna exclusiva. Fueron 150 pacientes a los cuales les administraron una mezcla de bifidobacterias y lactobacilos. Fue un estudio controlado, aleatorizado, doble ciego, placebo, que logró demostrar lo que en ese entonces también estaba reportado en la literatura, que fue una disminución del riesgo de la incidencia de enterocolitis necrosante en los estadios severos, disminución también en la mortalidad y en la variable combinada de enterocolitis y mortalidad. No así en sepsis y en algunas otras variables que se estudiaron. Fue en ese entonces, en el 2000, este artículo fue publicado en el 2013, pero el estudio se terminó en el 2009. Y en ese entonces la recomendación por el Instituto Nacional de Perinatología fue, basado en este estudio y en la literatura, de implementar o incorporar el uso de probióticos en el manejo estandarizado de los prematuros menores de 1.500 gramos para disminuir los estadios severos de enterocolitis y muertes relacionadas a enterocolitis. Sin embargo, no logró incorporarse al manejo estándar por un tema más que de soporte de la evidencia, de adquisición del suplemento, de adquisición del producto. En México, y esto para contestar la pregunta del doctor Soll de cómo está el uso de los probióticos en nuestro país, necesitaría también explicarle que hay dos tipos de acceso a la salud en estos recién nacidos prematuros. Tenemos instituciones de salud pública y tenemos instituciones de salud privada. Y en las instituciones de salud pública, para poder adquirir estos suplementos o algún otro tipo de fármaco, depende, por supuesto, de los recursos gubernamentales, porque ellos son los que lo soportan, y de las estrategias políticas de adquisición de suplementos y de fármacos que estén en ese momento. Entonces, en un país en vías de desarrollo como el nuestro, es complicado poder adquirir este tipo de suplementos que sí tienen un costo considerable, sobre todo para una estrategia de prevención, porque nosotros tenemos que manejar todos estos factores que les comento, sobre todo estas políticas de adquisición a nivel gubernamental. Entonces, hoy en día no está incorporado como una estrategia de prevención para enterocolitis y mortalidad en recién nacidos prematuros en ninguna unidad de cuidados intensivos neonatales de dependencia pública en nuestro país. Por ahí algunas veces consiguen alguna compra directa o se pide directamente a los familiares, pero no está como un proceso legislado y protocolizado. Sin embargo, es diferente en las instituciones de salud privada. Ahí los recursos van directamente, dependen directamente de los pacientes, de los propios papás de los prematuros. Entonces es mucho más común ver esta estrategia de prevención para los recién nacidos prematuros de muy bajo peso al nacimiento. Aunque cada unidad de cuidados intensivos neonatales tiene sus propias guías de manejo para esta población de alto riesgo, de manera general lo que se hace es justo un abordaje individualizado. Se establecen cuáles son los pros y los contras, y a menos que este prematuro no tenga criterios que contraindiquen de manera contundente el uso de los probióticos, como les comento, es mucho más fácil verlos como incorporados al tratamiento estándar, no solamente para lograr una mejor tolerancia en la vía oral, sino con el objetivo tal cual de disminuir el riesgo de enterocolitis en estadios severos y de mortalidad. Aunque en las terapias privadas la incidencia que se reporta es menor que en las terapias públicas, sobre todo en estas áreas marginadas que les comento, tampoco es nada despreciable. Va alrededor del 8 hasta el 10%, que es similar a lo que se reporta también en algunas unidades de cuidados intensivos en otros países. Entonces, les vuelvo a comentar que la enterocolitis necrosante sigue siendo un problema importante en esta población de prematuros que tenemos la obligación de seguir interviniendo para mejorar su evolución y el desenlace. Por último, quisiera decirles cuál es el estado de adquisición o cuáles son los productos que tenemos nosotros ahorita en nuestro país, ya que podemos adquirir de una manera más fácil. Desafortunadamente no tenemos la gama de variedad que hay en los países de primer mundo o en Estados Unidos, pero sí pienso que hemos mejorado mucho en los últimos años. Actualmente ya contamos con buenas especies tanto de bifidobacterias como de lactobacilos. Por lo pronto sí, las que ya están estudiadas y que nosotros podemos ver en la literatura, contamos ya con bifidobacterias de animalis de la especie Lactis. Tenemos, por supuesto, también Lactobacillus reuteri, tenemos Lactobacillus rhamnosus, tenemos Boulardii y también ahora ya contamos con mezclas que combinan bifidobacterias y lactobacillus. Tenemos una mezcla que es muy fácil de acceder, que trae justamente Lactobacillus rhamnosus, el GG, más Bifidobacterium lactum, que como ustedes pudieron ver en lo que ejemplificó el doctor Soll, son mezclas que ya están estudiadas y que se ha comprobado al menos la eficacia con las reservas en los resultados que vimos anteriormente. Entonces, bueno, esto a grandes rasgos es el panorama general del uso de probióticos en México. No contamos todavía con una estandarización y con el producto como tal a nivel público para el manejo y la prevención de enterocolitis necrosante y muerte en recién nacidos prematuros de muy bajo peso al nacimiento. Y en las instituciones privadas se individualiza y sí es mucho más común ver la utilización de los probióticos. Tenemos a la mano ya también las especies para poder adquirirlas de forma aislada a la institución pública. Muchas gracias.
Muchas gracias, doctora Roseli. Doctor Soll, pregunta a la doctora María Esther Santillán, ¿qué opina acerca del uso de probióticos en pacientes que han cursado con ayuno prolongado?
And I am not getting English translation. Ah, there we go.
Doctor Dagoberto, solo deme un segundito para que le pueda decir al doctor el valioso comentario que nos dio la doctora.
Ah, okay.
So, Doctor, before we go into the questions and answers, I'd like to translate the comment of Dr. Edna. This was such an interesting comment. She's giving us, number one, she wants to thank you for the great presentation that you've given us today with all the analysis, the evidence. And she was focusing on the history of the necrotizing enterocolitis in our country here in Mexico. So we know that the range of incidence, it's about 15%. The range is going to depend on which state we're talking about. As we know, this is a variability that has to do with the socioeconomics. So depending on the state that we are, they could go from 8 to 15 to higher. Some of the morbidity goes from 3 to up to 30% in some of the marginalized areas that we have in our country, where, as we know, the access to health is complicated. This is a big public health issue, has been, and there's definitely a need to decrease the mortality, the disease, also the morbidity, because as we know, there are complications and there are effects later could disable the kids. So she was mentioning that they've had more than 15 years of using the probiotics here in Mexico, but it's not in a standardized way. She mentioned that from 2009 to 2013, Dr. Carrocera did a study with 150 patients here in Mexico that they were receiving breastfed milk, but they also received a mix of the probiotics. And there was a reduction in the risk of the enterocolitis, mortality, and all, but not on the combination between other variables. There was a decrease in the combination of the variabilities between the necrotizing and mortality. Now, this study was published in 2013. So then the Perinatology Association recommended this to incorporate the probiotics into our babies that were less than 1,500 grams. What is the problem here? That we couldn't incorporate this in the protocols because of the lack of facilities or of the easiness of getting the probiotics. Now we need to explain, I don't know if you're aware that down here we have two different kind of systems for health. We have the public and the private system. So starting with the public system, what is the problem with that? To get this drugs, to get this medications, we need to have the governmental acquisition. They need to be able to buy the medication so that we can provide it to our patients. And that has been complicated because, especially of this factor. Some are able to get it like through a direct buy in the hospital they are, or families can get it. But like we've mentioned, this also depends on the socioeconomic level of the families. Now in private hospitals, this is different. The resources come straight from the families. So the prevention strategy is a little more common in these areas. They can individualize each case, do the plan, see what are the pros and the cons, and then focus on what that baby needs. The incidence is still, it's less than in the public area, but it's still important. It's 8 to 10% depending. And as we've mentioned, this enterocolitis, necrotizing enterocolitis is still a problem in the group of preterms. So the goal is really to try to find a way of preventing all this issues or all these complications that are coming up. In Mexico, we do not have the big selection like in the US or other first countries could have it. Yes, the good news is we have the most studied ones like Bifidobacterium, Lactobacillus. They've got some combinations, some mixes, and that's what they're using. But we just got to keep in mind that problem or the situation when we're treating a patient in the public health system versus in the private health system. Now, going on with the questions and answers. I don't know, doctor, if you
can I make, yes, I'd love to make a comment on that. First of all, thank you very much for taking the time to retranslate that for me. I picked up only a tiny part of it. And I think Dr. Rosley's comments are superb and really important. All evidence has to be seen in its context, and all decisions have to be made within that context. And she has given me a great deal of insight into the context in Mexico. And let me just make a couple of comments before we open to questions. One, if in fact your baseline rate of necrotizing enterocolitis is higher than the rates I presented from Vermont Oxford Network, and in fact higher than the rates that were reported in some of the studies, like in the UK and in Australia, it is fair to think that although your numbers are different, that the relative risk impact may be the same. And so the possibility then of probiotics in a situation where there is almost twice the rate of NEC means that all those numbers that I gave, suddenly, treating 33 to prevent one case of NEC becomes treating 18 to prevent one case of NEC, and makes your threshold for decision-making about the potential risks very different. And so under those circumstances, I certainly understand why hospitals may have said we should start in with using probiotics. I also understood there's a great deal of variation among centers, and all of the centers need to look at all the other factors of maternal health, amount of breast milk feeding, and other aspects of care. But the centers that do have higher rates of NEC, understandably, should be considering probiotics more strongly. You mentioned in the comments that it's hard to routinely get them in hospital on formulary, and there is some tension between what the private centers can do and the public centers can do. And that's a real issue, but ultimately, probiotics are an inexpensive drug. Okay, and if in fact you can make a strong argument because of your high NEC rate, it's an extremely cost-effective drug. I would, as a group, whether it's regional or not, try to use and find and source similar products that you think have multiple agents or combinations of products that create multiple agents. And it would be very interesting in moving forward if you worked together in a concerted way and began reporting this data to each other. Are we using probiotics? What are our NEC rates, et cetera? But it clearly seems like a big enough problem that caregivers in Mexico may view this data differently than people like the American Academy in terms of weighing risk and benefit. Now, I'll stop there, but I thought Dr. Rosley's comments were fantastic and very useful to me. Thank you.
Okay, Bueno, el doctor quería agradecerle a la doctora por los comentarios que dio, fueron magistrales, fueron importantes. Definitivamente es importante que toda la evidencia que se esté dando se tiene que ver en el contexto en el que nosotros lo estemos utilizando. Uno de los comentarios que él quería dar era de que si la tasa es mayor que la reportada en los estudios como en Estados Unidos o en Reino Unido, hay que pensar entonces que los números serían diferentes a los reportados o lo que el doctor estaba explicándonos, como en el riesgo relativo, ¿no? Cuando nos mencionó que teníamos que tratar a 30 bebés para poder prevenir en uno los problemas. En México, ahora esto podría ser, tenemos que tratar a 80 bebés para poder prevenir el problema en un bebé. Pero entiende también que hay una gran variabilidad en los centros y que se tienen que tomar en cuenta otros factores, no solo los del bebé, no solo los socioeconómicos, también tomar en cuenta los maternos, los aspectos de cuidado. Una gran idea que estaba mencionando es ver cómo justificar el uso de los probióticos para tratar de ayudar a esta situación de lo que estaban comentando la doctora de la diferencia entre los hospitales públicos y los privados, ¿no? Él menciona que los probióticos son económicos. Entonces, que se podría justificar tal vez verlo como entre diferentes grupos, unirse para poder decir de que, ok, tenemos centros con un gran porcentaje de incidencia de enterocolitis y podemos utilizar los probióticos que son económicos y nos van a ayudar en esto. Él menciona que tal vez podrían utilizar mezclas de los probióticos en cada centro, irlos reportando e ir compartiéndose entre los centros esta información. Estos datos se podrían ver diferentes. Obviamente es muy importante lo que mencionó la doctora y muy importante ver la comparación entre los datos que están dando en Estados Unidos, de cómo ahí la Asociación de Pediatría nos puede decir, hey, cuidado, pero porque el riesgo de incidencia aún es menor. Mientras que estando aquí en México, la incidencia es mucho mayor y nos tenemos que enfocar, tal vez no tanto en los cons de utilizar probióticos, pero más en los pros. No sé si tengan algún comentario, si no le puedo ya traducir la primera pregunta. Doctor Dagoberto está...
La doctora María Esther Santillán pregunta, ¿qué opina acerca del uso de probióticos en pacientes que han cursado en ayuno prolongado?
Doctor, what do you think about the use of probiotics on those babies that have been in without feeding for a prolonged time?
So it's a complex question. First of all, I believe that otherwise stable preterm infants should not be in the situation where they have not been fed for a long time. So I do believe in more aggressive early feeding. I think that although it does not increase NEC, and it may decrease the time on central lines, it may decrease infections. And so finding a window of opportunity just to feed these babies is important. But then, of course, you have that separate question, which the questioner may be alluding to, which is, okay, fine, let's say we had severe feeding intolerance, we had to hold feeds. I think they are particularly important in those babies. And the trials do not tease that out that well, but it's certainly, those are the babies we know have the most abnormal microbiomes and potentially could benefit the most from probiotics. And so there is potentially a role to say, okay, I'm not going to give probiotics to every baby, but the babies with feeding intolerance, or the babies I'm having trouble feeding, I think may well accrue the most benefit from probiotic supplementation.
Thank you, doctor. El doctor menciona, bueno, obviamente que si tenemos un bebé que está estable, pues no habría razón por la cual estarían en ayuno. Una de las prioridades es encontrar una oportunidad, una ventana de oportunidad para poder dar a los bebés la alimentación lo más pronto posible. Ahora, abordando específicamente la pregunta, si tenemos un bebé que ha estado en ayuno prolongado, puede ser que sea un bebé que haya tenido una intolerancia a la alimentación severa. Es particularmente importante en estos bebés, porque sabemos que estos bebés son los que tienen los problemas, tienen microbiomas no tan normalizados con alteraciones, por lo cual, por obvias razones, serían los que se beneficiarían más de los probióticos. Entonces, definitivamente él consideraría bien continuar con esto y darles el probiótico en los ayunos prolongados.
Tenemos un comentario del doctor Eduardo Casi, que también está de acuerdo, comenta que está de acuerdo en que es delicado establecer o sugerir una política general para el uso o la indicación de probióticos, ya que algunos centros han mostrado disminución de enterocolitis hasta un 6% con otras estrategias. Y bueno, comenta que las evidencias que se nos mostraron el día de hoy en base a los probióticos, pues le parece que es más una moda dentro de la medicina y pues no está claro todavía la evidencia a favor del uso general o de una política establecida de manera concisa. Yo quiero hacerle una pregunta, doctor, aprovechar su experiencia dentro del análisis de la evidencia y su intervención dentro de la red Vermont Oxford. Nos comentaba que se ha analizado la cantidad de centros que integran la red que utilizan probióticos es alrededor del 15%, y también el comportamiento de enterocolitis dentro de los centros que forman la red Vermont Oxford, que es alrededor del 10%. Mi pregunta es si se ha analizado por separado los centros que integran la red, los que usan probióticos y los que no usan probióticos, y cómo se ha comportado la morbilidad en estos centros.
So Dr. Dagoberto has this specific question about the analysis. So you were mentioning that on your presentation that it was analyzed a number of centers that use probiotics and the behavior of the necrotizing enterocolitis in the network, that it was around 10%. But has it been analyzed separately between the centers that have used probiotics and the ones that have not?
Wonderful question. Thank you. So the baseline rate of NEC in Vermont Oxford Network is probably more around 5 or 6%. And as you noted, up to now 15% of centers are using probiotics. The analysis that is suggested is hard because it is confounded, but yes, we have done it. But let's first speak to the fact that, understandably, centers with high NEC rates will be the ones motivated to consider starting probiotics. It harkens back to the questions we just had, where it may well be in Mexican centers with higher rates, they view the risk-benefit differently. So when we look at the Vermont Oxford Network centers, it's the same issue. Centers with high NEC rates are the ones that are going to be jumping on board and saying, I am going to be an early adopter of probiotics. So it's the centers that you're comparing are not really the same. That means two things. One is we all know that 1 year of bad performance, usually we regress back to the mean no matter what we did. And so we don't want to overinflate the fact that, oh, probiotics worked because it took what apparently was a bad outcome and they just got, as is normal, better. We have done sophisticated analyses to try to tease this out. And in fact, we have published a white paper on it as part of a little Vermont Oxford Network blurb, which I can send to people to take a look at, and are working with a publication with the epidemiologists at Dartmouth that does show that adoption of probiotics has a small measurable benefit on NEC.
Bueno, el doctor menciona que es una gran pregunta, muchas gracias. Sí, la base de enterocolitis es más como de un 5 o un 6%, hasta un 15%. Y que el análisis es difícil, pero que lo han hecho. Tal como se mencionó que en México depende mucho en el estado, en el centro que estemos, habrán centros que tienen con índices de enterocolitis más altos. Entonces, estos van a ser los motivados para utilizar los probióticos. Van a ver el riesgo-beneficio de una manera diferente. Entonces, estos centros son los que van a decir, vamos a iniciar con los probióticos de una manera temprana. Los centros que se compararon no son los mismos. Han hecho estudios sofisticados y de hecho él menciona que ellos han publicado un papel en Vermont que nos pueden enviar para poder verlo, donde muestra que esta adopción de probióticos sí tiene un efecto, sí se ve un efecto en la disminución de la enterocolitis necrotizante.
Gracias. Bueno, a manera de comentario, de acuerdo a lo que nos comenta el doctor Soll y lo revisado hasta el momento, los desenlaces a favor de probióticos que tendremos que valorar los riesgos del uso de los mismos es la tolerancia a la vía oral, ganancia de peso, disminución en el riesgo de enterocolitis, probablemente, y no tan claro su intervención en infección o modificación de mortalidad. En la población en la que se ensayó fue en los recién nacidos prematuros entre 28 a 32 semanas y entre 1 kilo y 1.500 gramos. Doctor Soll, ¿alguna recomendación o criterios que podamos tomar de manera más estricta para el uso racional y justificado de los probióticos con la evidencia actual en nuestra práctica clínica?
So, doctor, he mentioned the comment that we've seen how it goes down with the incidence of necrotizing enterocolitis, but not clear with infection, seeing the evidence on babies that are from 1 to 1.5 kilograms. Is there any recommendation that we could to use in a rationalized way on our babies in our medical practice, the use of probiotics?
So that's right to the heart of the question, isn't it? We are in a funny gray zone. And I'll go back to my statement. If you have a very high rate of NEC and you have some availability of probiotics, I completely understand why you'd be saying, I want to be an early adopter of this therapy. So I'm not suggesting you should do it, but let's talk about what you might do if you decide to do it. 1, make sure the staff is on the same page. Make sure they all understand why we're doing this, and make sure that we have protocols that assure the best care to prevent NEC up to that point. So protocols about how we harvest and support mothers who are supplying their own expressed breast milk. Protocols about how we store and give breast milk. And then identification of which infants might benefit from probiotics and how we will obtain and get those probiotics. So in terms of which infants, I would argue that because of the rate of NEC, that certainly even very low birth weight infants or babies less than 1250 grams might be your net for that. I would start with the early initiation of feeds. I would not wait some time because we're talking about colonization. I would have a standard preparation that we use and either bring it on formulary or in situations where families have to buy it and bring it in, you at least tell them specifically what to get. Some centers in Australia have taken any batch of probiotics and sent it to some portion to the microbiology lab to make sure that it's not contaminated and that in fact it's what they think it is. That's taking it pretty far down the line, but just to tell you that some places have done that. And I would consider engaging families, either to tell them that we're doing this and they can say, please don't, or asking them, we recommend this, can we go ahead? But I would engage the families in what I was doing in some fashion, either an information sheet, or once you say, we have a policy of doing this, but if you say no, we won't, etc. So it's a systems issue. I think that, as you can see, 15% of Vaughan hospitals, of which that means in 90% of the hospitals in USA. So, 15% are doing it. So some people are deciding that the scale has tipped and they should. So I hope that's useful. I'm happy to entertain other questions, but I certainly understand why you'd be thinking about it, but I think it has to be a whole systems approach about feeding, what to use, and how to incorporate the families in the decision.
Entonces, esto es como una zona gris. El doctor quiere regresar al comentario que había dicho donde si hay una tasa elevada de enterocolitis y tenemos la disponibilidad de los probióticos, entonces él entiende el por qué se quieren utilizar los probióticos. Ahora, no está diciendo que él recomienda el uso de los probióticos, pero si ya decidieron que se van a utilizar, entonces, ¿qué es lo que se tiene que hacer? ¿Cuál es el paso? Asegurarse de que todo el personal esté en la misma página, que todos estén al tanto del uso de los probióticos, que hayan los protocolos establecidos, que se aseguren que se esté llevando el mejor cuidado para prevenir la enterocolitis necrotizante, que estén los protocolos de cómo hacer las tomas de leche de las mamás, cómo se van a estar guardando los paquetes, identificar qué bebés son los que en verdad lo van a requerir. Si tenemos en términos de aquellos infantes que tienen el peso menor de 1,250 gramos, entonces con esta tasa de enterocolitis sí ve la razón de utilizar los probióticos. Él se enfocaría en iniciar la alimentación de manera temprana, tener una preparación estándar y traer esta preparación de probióticos en las fórmulas. Si los familiares son los que tienen que comprarlo, especificarles cuáles son los que requieren, cuál es el que necesitan comprar. Algunos centros en Australia toman muestras de estos probióticos y lo envían a los laboratorios para asegurarse de que no estén contaminados y que en verdad sean lo que dicen que son. Esto igual sería como que llevarlo un poquito más allá en la línea, pero es algo que se tiene que considerar. Algo importante también es traer el abordaje a la familia, decirles qué es lo que se está recomendando y si están de acuerdo con realizar esto, con darles a los bebés los probióticos. Se puede decirles que es la política de la instancia en caso de que lo sea, pero la decisión de ellos, ¿cuál sería? Lo que había mencionado el doctor de darles la información en hojas, de comunicarse con los pacientes, con sus familias. También menciona, bueno, está viendo que el 15% de los hospitales lo están haciendo. Entonces hay unos cambios en la escala, un abordaje que se está llevando de que tal vez, oigan, sí se debe usar los probióticos, sí son buenos. Esto definitivamente es un abordaje que se tiene que hacer de todo el sistema una vez que se decida que ya se va a dar en los probióticos. Él está feliz de abordar un poco más en esta cuestión, alguna otra pregunta, no sé con qué quisieran avanzar.
Doctor Soll, los comentarios de agradecimiento superan y felicitaciones superan en mucho a las dudas. Por temas de tiempo vamos a cortar aquí la sesión. Le agradecemos muchísimo a nombre de la Federación y de todos los que participaron en este webinar. Y también agradecemos a todos los participantes por sus comentarios y sus preguntas. Muy buen día a todos.
Thank you so much, Dr. Soll. Because of the time, we're going to go ahead and wrap it up. But we do want to let you know all the comments on our chat are all thanking you so much for such a great talk that you had today, such an important role. So we just want to go ahead and wrap it up. Thank you one more time. Don't know if you have any other comment to translate.
I just have one, and that is I am really honored to be invited. Our work, both at Vermont Oxford Network and at Cochrane Neonatal, the whole point is to share it and to learn about how you guys might use it, and for me to contemplate the nuances around that. So I'm honored, and I thank you, and it's really a pleasure.
Ha sido honor para mí recibir la invitación. Definitivamente la información que realizamos en Vermont y en la red de Cochrane es para traerles la información, pero para que nosotros igual podamos visualizar cómo va esto afectando en cada lugar. Entonces ha sido un honor para mí poder compartir con ustedes esta información. Muchísimas gracias.
Adiós.